So it's now a pleasure to introduce the members of our second panel of presenters for the morning. Dr. Zenobia Arsuliak is a psychiatrist who works in the early psychosis program. During her psychotherapy fellowship in that program, she actually developed a wellness program for young people in which motivational interviewing was certainly an essential key component, and she's gone on to make that a key component in terms of her practice with that population, but as well, she certainly does a tremendous amount of teaching of motivational interviewing to a wide range of mental health clinicians. Dr. Celine Etches is a child and adolescent psychiatrist whose major clinical and research interest is in comorbid substance use disorders in young people, and she's the medical director of the IWK Concurrent Disorders Program. And Scott Jansen is a master's level social worker. He's actually a member of the Motivational Interviewing Network of Trainers. And in his one of his current roles as clinical practice educator in the Central Zone Mental Health and Addictions Program, he has extensive experience, obviously, providing training and motivational interviewing, not just to mental health professionals, but has actually extended that to allied professionals in the community. And I'll turn things over to our panel.
Well, good morning, everyone. My name is Scott Jansen. Along with my colleagues Zenobia and Celine, thank you for letting us be a part of your day today. So we're going to take about an hour and talk a little bit about motivational interviewing. Basically a way of being with people to help them engage, develop some focus, evoke from them their reasons and ability, and help them develop a plan for healthy behavioral change. Before we jump into it too much, a couple disclosure pieces. Some people might have picked up on the fact that Janssen Pharmaceuticals is spelled exactly like my last name. There is no family relationship. Trust me, I checked. You'd think there'd be at least one cousin in there or something, but no such luck. Before we get into it too much, I just want to thank the last group that presented. I really liked their analogy about Mr. Anxiety riding on the bus. For me, he's not just riding on my bus, he's sitting on my lap, which is a little awkward. So having said that, I feel obligated and ethically obligated to inform everyone here that for the next hour, you're all just sitting there in your underwear. I appreciate that. Very quickly, what we want to cover in the next hour, to understand how healthcare providers can influence intrinsic motivation in others, to recognize ambivalence as a natural step in the process of change, and finally, to become familiar with the engaging skills of motivational interviewing. Now, my part in all this for the next 11 minutes or so is to set a little bit of the groundwork before Celine and Zenobia take over. So to that end, I always like to start with a quote from Plato. The greater part of instruction is being reminded of things we already know. So having said that, a couple quick questions for you. Just a show of hands, how many people here really appreciate being told what to do? And I'm not talking about when you're actively seeking out direction or guidance from a colleague or a friend or somebody in leadership. I'm talking about that good old-fashioned, unsolicited, you know what you should do? You know what you got to do? You know, you really have to, whatever. Second question, how many people here, again, show of hands, really enjoy being told you're wrong? Again, not when you're actively seeking direction or feedback. Particularly when it's being addressed to something that's really important to me, something part of my worldview or my beliefs or my values. See, those two things I am very well aware of. I think most people here in the healthcare business are. People don't like being told what to do, and people don't like being told they're wrong. And yet, and I'll speak in the I, and yet, I can so easily in a clinical contact find myself getting frustrated because I'm more motivated for the patient or the client to change than they are, it comes out. What you got to do is, because whatever you're doing is wrong. And I'm surprised that I get some resistance and pushback. Has anybody here ever been on the receiving end of a yeah, but? Anybody here have kids? Anybody here married to me? Okay. Yeah, but. There's very little yes in a yeah, but. Yeah, but actually means no, because. And it's often a reaction if people are feeling pressured or think they're being told what to do or they're wrong. Has anybody here ever given a yeah, but to a patient or a client? That often happens too. People don't like to be told what to do, and people don't like being told they're wrong. That also applies to people in healthcare. We push back sometimes. So besides those two issues, I just want to go over some guiding principles that I think to keep in mind as Celine and Zenobia take over. Healthy behaviors are often abnormal behaviors. What I mean by that is we often ask people to do something that goes against that pleasure-seeking principle that's alive and well in all of us. Not to mention that a lot of the clientele that I work with, I'm sure you work with as well, have conditioned themselves in a certain way. And so right out of the gate, I'm asking them to do something that goes against their conditioning and the pleasure-seeking principle. Healthy behaviors are often abnormal because they go against the pleasure-seeking principle and they're based on delayed gratification. And something that I can easily forget. And again, I wonder why I'm getting pushback. Why wouldn't you want to make healthy changes? Because people do things for reasons. And my first task is to understand why they do what they do before I ask them to make any changes. People are influenced more by their own voice than by others. Have you ever had a session with somebody where it's just yeah, buts back and forth, and at the end of that session, what I've done inadvertently is help them remain stuck or even strengthen the position that they came in with. People are influenced more by the sound of their own voice than mine. People are more interested in their own reasons to change than mine. And that's the task. It's easy for me to provide all sorts of reasons why people should do anything. I went to school, I've been doing this for a long time. And yes, we do have expertise. The thing is, people don't like being told what to do. My task is to elicit from them their reasons why they might be interested in change. Our task as healthcare providers is to help people become willing to do what is healthy. That sounds pretty straightforward, an easy thing to remember in a nice, calm, relaxed setting like this. It's quite another when somebody's in front of me. I can put a lot of pressure on myself that I have to change somebody. Maybe that pressure is coming internally, and sometimes it comes from the system we work in. We got to get these people through. There's people behind them. The harsh reality is, I can't change anybody. My task is not to change anybody. And I can put a lot of pressure on myself if I think it's my job to change people. I wish I could. I'd be making a lot more money. It doesn't work that way. My task isn't even to get them to want to change. That's setting the bar pretty high. I don't expect anybody to want to quit drinking, want to quit gambling. Drinking and gambling, I always did what I was supposed to do for those people. My task is to at least get them willing to do something, despite the positive short-term effects of whatever that behavior is, to help them become willing to do something different. Finally, it's not the message delivered, but the message received that is important. Having said that, as a 230-some healthcare clinicians and providers in the room, smoking, good or bad? Shout it out. Bad. And we'd be absolutely wrong. My question wasn't, is smoking healthy or unhealthy? My question was, is smoking good or bad? As a clinician or healthcare provider, I have a built-in bias. I often associate healthy with good, unhealthy with bad. Look at it from the lens of the patient or the client. I don't know if anybody's ever worked smoking cessation. I know some people here have. But if you ask that question to the group, what often happens is, good. It's awesome. I miss it so much. But we can take it outside the realm of addiction work. We can put it in mental health. Somebody who's severely depressed and spends a lot of time in bed. Staying in bed, good or bad? Knee-jerk reaction is bad. We want to get you out of bed. We want to get you activated in society. From their point of view, it's not that they enjoy staying in bed, but it's better than. So in that context, staying in bed is good. If I'm not aware of this, I can start from an adversarial position as soon as I meet that person. And again, I get a lot of resistance and pushback. And I don't understand because I'm on the side of angels. I want people to get well. I really am. I'm not sure why people are laughing at that. Okay. But I am. But I'm surprised that people aren't as motivated as I am to do what's healthy. A couple quick definitions of motivational interviewing, because that's what we're here to talk about. The first one, MI is a collaborative conversational style for strengthening a person's own motivation and commitment for change. Very quick, very subtle. If you want to go a little deeper, they also provide MI is a collaborative, goal-oriented style of communication with particular attention to the language of change. And that's important. We spend a lot of time in training helping people recognize what language of change sounds like and how to respond appropriately. It is designed to strengthen personal motivation for and commitment with a specific goal by eliciting and exploring the person's own reasons for change within an atmosphere of acceptance and compassion. I don't expect anybody to be able to remember that at the end of the day. So I like the third one, and this is provided by Stephen Rolnick, one of the designers and implementers of motivational interviewing. MI is a gentle conversation about change. Have you ever come out of a clinical contact with a patient or client exhausted? It resembled a little bit like a verbal wrestling match. It's just me? Okay. That can happen. It can happen. If that's happening, there's a good chance I'm not taking a real MI stance. I'm not rolling with resistance, and I am very, very committed to getting my point across and trying to change people. If it sounds and feels like a wrestling match, it's probably not MI. Quick look at intrinsic motivation. And we talked about the first one already. People learn what they believe by hearing themselves speak. So who should be doing most of the talking in a session? The client or the patient. People learn what they believe by hearing themselves speak, either in a healthy way or unhealthy way. The writing reflex, that's a term we attach to my desire to fix things. If I recognize or I interpret as something that the patient is doing that I think is wrong, I want to fix it. I want to make it right. Again, how many people here like being told what to do? How many people here enjoy being told you're wrong? I know that here, in a nice, calm, relaxed setting. But you put somebody in front of me, I can easily fall into this. And it's usually preceded with the yeah, but from me. I like to try to make things right. Again, I'm operating from the side of angels. I have good intentions, but people push back. And they push back with their own writing reflex, particularly if somebody's ambivalent about change. I want to, but I don't want to. If I only argue one side of that ambivalent issue, they're going to pick up the slack and argue the other side. And whose voice has the greatest impact? Theirs. I have inadvertently helped them stay stuck. The theory of psychological reactance. Essentially, if you want to make something tempting to somebody, tell them they have to stop it. You can no longer have coconut cream pie, Scott. Well, I never thought about it till now, but now I want a piece of coconut cream pie. You have to quit gambling. You got to quit smoking. The reality is they don't have to do anything. And all I've done was make it very tempting to do so. People take their autonomy very serious. People don't like being told what to do. Even if it's in their best interest to make that change, people protect their autonomy. So that theory of psychological reactance is always something to keep in mind whenever we're working with somebody. Not just in a clinical setting, but even from a leadership perspective. Telling people what to do is quick, it's expedient, and they might get short-term change, but it's not based on intrinsic. What am I doing for time? 3 minutes. So we try to make this point a lot in training. MI isn't simply a collection of techniques. There are techniques involved, obviously. But what's more important, and what can easily get lost, is the spirit of the thing, the philosophy. And a nice way to remember it, MI loves its acronyms, PACE. The first one is partnership. Understanding where our jobs start but also where our jobs stop. We can't change anybody. We can guide, we can influence, but really the change has to be intrinsic if it's going to be sustained. Each person in that relationship, the therapeutic relationship, has a role to play. And I say that because I can easily forget that, and I can get discouraged and frustrated because people aren't changing. What am I doing wrong? How come I'm not doing my job right? The reality is, people have to take responsibility for that change. Doesn't mean that I can phone it in or it's a free get out of jail free card. I have a pretty significant responsibility as a clinician, but I can't do it all. Simply telling people what to do doesn't work. It's a partnership. Acceptance. Smoking good or bad? I have to accept that for them smoking is good. I'm not condoning it or agreeing with it. It's a starting point. I accept the person for who they are and what they're doing. I have to start from that position. Compassion. Miller and Rolnick, who designed MI, added compassion actually fairly recently because people were getting too caught up in the techniques and they forgot the spirit. And one of the biggest pieces of the spirit is simply the compassion. And compassion should not be confused with, I feel bad for anybody. Compassion speaks to who's ever in front of me has my complete and undivided attention. I'm not checking my email, my mind isn't wandering, I'm not working on my golf swing in my head. I am paying attention to that person. That is what they refer to as compassion. And finally, evocation. It'd be really nice if I could hang an IV bag of motivation and say, there you go. We can't. Which is probably just as well because I'm not medically trained and there's a lawsuit waiting to happen. We don't hang IV bags of motivation. I have to evoke from them. I can't put motivation into somebody. We're not motivational speakers. And there actually have been some studies about how long does the effects of a good motivational speaker last? Usually less than a week. Because we can't put motivation into anybody, but we can evoke it from them. We ask lots of open-ended questions so they can hear themselves talk about the upside of change or the downside of not changing. 1 minute. Very quickly. So the language of change, again, the acronyms. Start with DARN. What I'm fishing for is to help the client use statements of desire, ability, reasons, and need. I want to change. I can change. If I change, then this will happen. Or simply, I really need to do something about this. So that's DARN. CAT. The CAT part of change talk is actually a little stronger. I am going to do something. That's that commitment language. And activation, I swear, I think they just had to come up with a word that started with A so they could spell out the word cat. Activation refers to willing to do something. And the T stands for taking steps. I really want to get into better shape. I haven't started working out yet, but I bought a gym membership and a new pair of sneakers. I've taken small steps. This sounds pretty straightforward, but you'd be amazed how easy it is not to hear it in a conversation. MI is as much about linguistics as it is about psychology, and it's training ourselves to pay attention to the language of change and to use it when we hear it. The most basic of human needs is the need to be understood. The best way to understand people is to listen to them. Thank you for listening to me.
So does everyone have this piece of paper? So if everyone can get it out, yeah, because myself and Zenobia are going to use that. And this, you're going to have to get personal. You don't have to share it, but also please don't go too deep because we don't want to have to put you back together, right? Okay. We want you to think right now of a change-based behavior that you're considering in your own life, right? That you're not quite sure about. So you're not quite at the point where you're doing it. You're just kind of thinking about it. Maybe it's something you used to enjoy, but you're not doing anymore. Maybe someone else wants you to do, but you're not quite sure that you want to go there. And maybe just something you've been thinking about doing, but you just haven't quite started yet. So just take maybe a minute and think of that change-based behavior for yourself. Often it is exercise, but it doesn't have to be in this setting. And write it on the number 1. What change are you considering? And it's important you do this because this is going to infuse the session, everything that I'm doing. So please do it. All right. Everyone pretty much there? We're not going to get you to say it out loud. If we did get you to say it out loud, like Scott said, hearing yourself say it out loud would strengthen your motivation just by saying it, right? It really is important, the verbal, in motivational interviewing. So when we look at change, and when you look at your patients, and we look at mental health care and healthcare in general, what we know is that there's different stages of change that people are going to be in, right? So there's different periods that they go through, and this is a natural progression, but it's not a linear progression, okay? But we have these different stages, and the first one is pre-contemplation. Nope, I don't really have a problem. My parents might have a problem. My spouse has a problem. My boss has a problem. I don't have a problem. It's everybody else's fault. It's everybody else's issue, not mine. Contemplation is, well, maybe I have a problem, but maybe I don't. I like what I'm doing, but I don't like what I'm doing. I'm not sure. You're weighing both sides. Determination, preparation is like, yeah, I got a problem. I got to do something about it. Maybe I'm going to go out and buy those running shoes. Or I'm going to go buy the bike rack so I can get to the biking. But you're not actually doing it. Action is, yeah, I'm going. I'm at that gym. I'm making those changes. I'm going to counseling. And maintenance is, I've made the changes. I'm sticking with them. And relapse is, I want you to really notice this, that's a natural step 2 in the process of change, right? And you can go through any of these. And what's really important when we think of mental health care is that when we see patients, 80% of the people we see are in pre-contemplation or contemplation. Only 20% are in that action preparation type change-based stage. And so many of our therapies are based on that action maintenance stage of change. Come in, I'll teach you how to manage your thoughts. I'll teach you how to manage your behaviors. But what if the person's not sure? And it's so critical to match your intervention with the stage of change they're in. Because if I'm at an action stage of change as a therapist and the patient is pre-contemplation or contemplation, I'm actually going to make them more stuck in that stage of change. Okay? And I also want you to recognize that ambivalence part of things, that contemplation, that's a totally natural step in that progression of change. And don't be discouraged. And don't be discouraged if you're there. So a really frustrating thing as a therapist is that you've maybe worked so hard to get them to that action stage, and then all of a sudden they shift back to contemplation. And then you're like, no, you were there. I want you there, and I'm going to keep you there. And then you continue hammering on the action. You're causing harm, right? So it's very, very important as a therapist to recognize the stage of change, match your intervention. So when you think of yours, so people are at different stages of change. One stage does not inevitably lead to the next. You can get stuck, okay, at one stage, and that's fine. Sometimes that first step towards true change has become ambivalent. So you need to recognize what different people are going to be saying at the different stages of change and celebrate that. Because if someone has gone from pre-contemplation to contemplation as a result of your efforts as a therapist, that is so fantastic, and celebrate that. Relapse is a normal part, and you can help influence the movement. You absolutely can as a therapist. So one thing that really frustrates me personally is when people come in and say, you know what, I could help this person, but they're just not ready. It's like, no, you could help this person to make them be ready, right? And that is what motivational interviewing helps you to do. And you get that a lot in the substance using world, right? They're just not ready to change. Completely negating your own responsibility as a therapist in that. So, number 2 exercise for you guys is with respect to your own change-based behavior, think back and say, what stage of change am I in? I'll put them up for you again to pre-contemplation, contemplation. Are you preparing for change, action, maintenance, or have you relapsed? And write that down. So Scott was talking a lot about the spirit of motivational interviewing. What Zenobia and I are kind of a little bit more focusing on as well as some of the techniques or skills. We really want to emphasize that those skills and techniques are pretty much useless if you don't embody the spirit of the practice. So we're giving you a taste of things, but please don't leave here just thinking, okay, I'm going to pull out a readiness ruler or pull out a stage of change or pull out the decisional balance, which I'll show you next, and think that's going to be the answer, because it's not. It's not a bag of tricks therapy. It really is a way of being with patients. And it's a way of being with patients so you don't burn out, especially with those 80% who just aren't ready, okay? So the readiness ruler. This is a self-evaluation tool to look at where an individual is with respect to 3 different components of change, and that's importance, confidence, and readiness to make a change. So, the willingness aspect of it, the importance, is that degree of discrepancy between what is happening right now and what that person's values is, what their future motivation is. Okay, so how important is it for them to make that change? Able, and we miss this a lot in therapy, right? We can get them to the point where, like, I really, really need to make this change. This is so important to me. And we neglect to recognize that they're not so sure they can do it, right? And in that sense, we've actually caused harm to these people because we've really made it super important that this happens, and then we've left them with this feeling like, even if I try, to be useless, right? So that's that confidence for change, and there's 2 areas. There's the general efficacy, so it's a change that they think will work. So if I actually went to the gym, I would lose weight because going to the gym does that. Or self-efficacy, that they actually believe they could do it. My body works that way. I could go to the gym. That's something I could do. So there's 2 components to that. And motivational interviewing, as you learn, it helps you build that confidence in people, okay? Which is something I do believe that we neglect sometimes as practitioners. And then readiness, so that relative priorities. So am I ready to make this change right now? And that's where you hear a lot of the yes, but. And I just want to give an example of a patient I was seeing in Toronto when I worked there at the Centre for Addiction and Mental Health. And it was a young girl who was actually from Nova Scotia, so that's why I bring her up. And she was about 22, and she had 2 young children back in Nova Scotia that had been taken under the care of Department of Community Services here. And so we were going, she was saying, well, one of my things that I really want to consider is getting my kids back. And I said, okay. So we did this readiness ruler. How important is it for you to get your kids back? 100% important. They mean the world to me. I really want these kids. All these things. Okay, 10 out of 10 on that readiness ruler. How confident are you that you can get them back? 10 out of 10. I've talked to Department of Community Services. I totally can if I want. So I thought, okay, let's see. I called Department of Community Services. Oh yeah, if she wants to come back, we're happy to do that. We want her reunited with these kids. Okay, 10 out of 10. How ready are you to do this right now? I'm a 2. A 2? Why are you a 2? Right? Because that's weird. It's so important for you. You're so confident you can do it, but you're not ready? No, because when I was 5 years old, I was taken away by Department of Community Services from my own mother. And I remember being ripped from her arms, and I remember having that trauma. I'm not sure I can go back to that point, right? So very different aspects in that change-based process that I would have missed. So for you guys, thinking of your change-based process, complete your own readiness ruler right now. How important is it to you right now to make that change? On a scale of 0 to 10, where 0 is not at all, not very important, and 10 is, oh gosh, I gotta do this right now. How confident are you that you can make the change right now? On 0 to 10, again. And how ready are you to make that change? 0 to 10. Can people see? Was everyone at a 10 out of 10 for all of the 3 rulers? Show of hands. If you were, you'd probably be in action state, right? Okay, did people's rulers different? Like were some 8, some yeah. So it shows you how, as a therapist, you need to address the different components of change. Not just think of it as a behavior to make a change or not. There's different areas. So if you were doing this with a patient, you would do follow-up questions, right? And you would be very careful, again, in your language, as Scott said, because it is about language, right? And I'm always harping about language to residents and to staff and to parents, and just give the example of the language of substance use disorders, because that's obviously my passion, my love. And you think of the language and you say, well, this person's urine is clean, okay, when you do a urine drug test. Well, that language is so, so important. When I'm saying you've got a clean urine or a dirty urine, what am I saying about that person, right? So I never, ever, ever use language like that. Or I'm just going to get clean. Terrible, terrible thing. And it's really important when I change that into you have a drug-free urine. You've been abstinent for a long time. That's really important in how then you view the person, right? So that's just a little sidebar about the importance of language, but motivational interviewing is really important about language. And this is in this example. So why are you at this number? So if you were saying ranking your importance to change at a 6 out of 10, I would say, why are you a 6 and not a 3? I would never say, why are you a 6 and not an 8? Okay? Because if I say, why are you a 6 and not a 3, they're going to give me all sorts of reasons why it's super important to them. If I say, why are you a 6 and not an 8, they're just going to list out all the reasons to not change, right? And you always want to keep your conversation about change in the direction of change, getting people to speak their change-based ideas out loud, right? Because they learn what they believe when they hear themselves speak. So that's really important. When you hear people doing non-change-based talk in a session, change your strategy, right? Because you're doing harm in that session. And then you could say, well, what might it take you to move to a higher number? How could I help you move to a different number? What would be important to move you from a 6 to an 8? So ambivalence. Scott touched on this as well. People are always motivated for something, okay? Their goals might not match our goals, but they are motivated for something. It's not that a person is unmotivated or not ready. They are motivated. They might just be not motivated for what you want them to be motivated. The conflict arises, of course, when people are motivated towards different goals. So the question becomes that you really have to look at is not why isn't this person motivated, but instead for what are they motivated, right? And then you explore how that current problem behavior, and I put that in quotes, right, because it's a problem because it doesn't match your ideas, is hindering them in relation to their other motivated goals. Because, as Scott said too, people are best persuaded by the reasons that they themselves have discovered than those that come into the mind of others. So proposing a whole bunch of solutions usually is not that helpful. So a technique for this, and I want you to flip over to this page of your handout, is something called the decisional balance, also called the 4-way window technique. Some people may have seen this in the past. And what it really looks at is those different sides of that ambivalence, okay? So you always start with the good things about the current situation, right? And so for the youth I work with in substance abuse, this really throws them, right? Because they're so used to hearing, don't use drugs, don't do this. And when I come out and I say, what are the really good things about using crack cocaine? You're like, pardon me? Aren't you going to get your finger out, right? So you always start with that. Right? What are the good things about your current situation? Then you move to what are the bad things about your current situation? And then you move to if you changed, what would be bad about change? Which sounds very much like box number 1, but is incredibly different. And then you move finally to what are the good things about changing that you can see. I'm just going to show you an example of a patient that I did. This is from a 15-year-old girl. She's given permission to share it. She actually wanted me to share it to help others. So I'll show you hers. This is from my substance clinic. So what are the pros of her current situation of using drugs? Making friends because they need drugs and I have it. Not feeling or remembering my past. Boosting self-confidence. Not needing family, which is good because I don't have any anyway. Being happy. Doing nothing. Being content. What are some bad things about being right now? Remembering everything you did when you were high. The drug enforcement cop knows your name when he drives by. Becoming the drug. Having scars, wanting it all the time. So that loss of control. If you changed, what would be bad about that? Being alone more of the time. Living in a town of pills, cocaine, having to cope with all that temptation. Still being seen as an addict even though you've been made the change. Not having that trust build up. Feeling obligated to do things that are normal. Gaining weight. Hating myself. And what would be some good things if you changed? Being allowed to go back to school, not having that dependence, learning about myself, whether it is good or bad, trust again, health come back, and not having to lie all the time. So really complex, right? So this isn't a 15-year-old girl snorting pills and injecting drugs. Yes, she is, right? but look at the complexity of all those reasons for why she's making those behaviors and why she wants to change. So that's somewhere to go, right? Rather than just giving a label or giving them, anyway. So what I want you to do now is just complete your own decisional balance, just because of limitations of time, just maybe one thing in each box, okay, on this. And if you could do it in the order, because you do always want your session to end on a change note, right? You never want them leaving out the door talking, say, box number 3. You always want them talking good things about change as they leave your session. So just one thing in each box. A good thing about staying the same for you, so not changing your behavior. Bad things about the fact you're not doing it. Bad things about changing. And then good things about changing. I'm going to turn it over to Zenobia now, and she's going to talk a little bit about some of the core skills when you do learn motivational interviewing. So thank you very much.
All right. So I'm going back to the spirit of motivational interviewing before I go into the core skills, because it's such an important, if you are not in alignment with these core principles or core beliefs about motivational interviewing, the core philosophy, then when you practice the skills, they're going to fall flat. And if you don't remember a skill, if you can keep in alignment with this spirit, then you're going to continue to do well in motivational interviewing. I want you to look down at your decisional balance. And what you wrote reflects maybe your values, your goals, and your knowledge about the unique situation of your life. That's not something that I know about. That is your expertise, and that's why having a partnership in motivational interviewing is so important, because knowledge and awareness of those factors are going to help you to make a successful behavior change. And I don't know that about you, and so I can't assume that I am the key person going to make this behavior change. I need to evoke all of that from you so that we can look at that together in a partnership. That's what you contribute. That's what a patient contributes in that partnership, or at least one aspect of that partnership. So the essential skills, this is just the first set of skills. This is all we have time to get into today. These are the set of skills that allow you to engage with the client, the first step in motivational interviewing. And we love our acronyms in motivational interviewing. So the acronym for these skills are called OARS. With OARS, you can paddle. The first O is open-ended questions. Then there are affirmations, reflective listening, and summaries. These OARS skills help you to build rapport, support the patient's self-efficacy, and help build motivation through eliciting change talk. So open-ended questions are questions that encourage a rich, thoughtful reply, as opposed to a closed-ended question, which you just get a short response. If I was to, some stems for open-ended questions would be what, how, tell me about. If I was to ask you, the audience, an open-ended question, I might say, what would you like to get out of participating in today's session? Can you tell me about that? And hopefully I would hear several things, not just one brief response. They allow you to evoke the person's own ideas about why they should change and how they can change. And that, again, supports the patient's self-efficacy. The next strategy, the affirmations, they're statements to recognize clients' strengths, their successes, and their efforts to change. They're not exactly the same as praise, and when you give them, you avoid using the I statements, like I like this or I think that's great. I mean, maybe if you really know the patient well, they might accept that. But what I suggest is to listen for what they've done well or strengths that you've noticed in them, and reflect that back, starting the affirmation with you. And only give an affirmation when it's genuinely felt. Don't create some sugar-coated saccharine piece of praise that you think is going to win them over. Give an affirmation when you genuinely feel it. Now, the caveat to that is that in our society, I think it's a cultural phenomenon that we're not very good at affirming each other. And so if we're not good at a society of giving out affirmations, just imagine how patients feel, who most of them have probably been raised in environments where they have experienced neglect or abuse, or currently living in environments where they have interpersonal difficulties. How much are they getting in terms of affirmations in their day-to-day life? And that's why I'm highlighting this, because it is an important skill. And when I teach people how to do motivational interviewing, they kind of feel a little bit uneasy giving affirmations because it's not something we generally do. And then once they start to open their hearts and see how it works, then they get more and more comfortable with it, and they realize that, oh yeah, I do generally want to give this to my clients. So I could give you all an affirmation right now. I could say, you guys are all great. But what would that mean? I'm not really clear to you what you're great about. So when you give an affirmation, be clear to the patient what you're affirming. So I could give you another affirmation. I could say, you have shown a lot of dedication and genuine interest in learning by coming to this program today and engaging with it. And that's going to help you to be better at whatever you choose to do. Did you feel better? Anyways, reflective listening is a powerful strategy for building rapport, diffusing resistance, demonstrating empathy, and overall enhancing motivation. It shows the patient that you understand the meaning of what they're saying. And it allows the speaker, the patient, to hear what they're saying a second time. Just like Celine and Scott said, people are more influenced by their own voice than yours. So when you reflect back to them their reasons for change, their belief in their ability to change, then they hear it a second time. And it's their own reasons for change, not yours. Reflective listening is a reasonable guess as to what the client means. And it's given as a statement rather than a question. And a lot of people can, when they first learn how to do reflections, they will raise the pitch of their voice at the end of the statement. And when you do that, it sounds like a question. And after, which may be okay for initially, but as an interview goes on and you keep doing reflections that actually sound like questions, the patient will think, do you really understand me? Are you getting this? Rather than if you just reflect back to them as a statement. We try to aim for a ratio as for every question you ask, you should have 3 reflections. So you're asking way less questions in motivational interviewing than you think you should be. You always reflect change talk so they can hear it again. And whenever I get stuck, if I momentarily lapse out and I don't think about my golf swing, but I don't know, let's say I'm thinking about something else in my life and I momentarily lapse out. If I want to bring myself back into the session, or I'm feeling really anxious, whatever reason that I have disconnected from being in the present moment, if I can remember what they just said and reflect it back, then I can move that session along. I use it whenever I get stuck. So a simple reflection can be as easy as just repeating 1 or 2 of the words or changing the wording slightly. For example, a patient might say to me, "Who are you to give me advice? How do you know what it's like to have a drug problem anyway?" And you could reflect back to them, "It's hard to imagine that I could really understand." A reflection can also go beyond just the content of what they're saying. You can reflect the emotions that you're observing. And that actually can work better in some cases to build rapport. So let's say, I don't know if any of you have ever worked with a client that didn't want to be working with you. Maybe it was an involuntary patient or someone who was mandated to come to this session. And so you're trying to engage them in an interview and they're not answering questions well. They're just giving you the briefest of response. They're not looking at you and they look angry. And so you can reflect to them, you're angry about being here and you don't want to be talking about this. And that can actually open them up to feeling really understood and heard. And I've used it on call with involuntary patients, and I have proof. If Josh Schmully's here in the audience, he saw it, and he saw it actually opened up a client and then got them talking. A double-sided reflection can be really great in that it can capture that ambivalence. So for example, a patient says, I don't drink that much, I just drink to take the edge off at the end of the day, and it's not like I'm one of those bums on the street sleeping in a cardboard box. So you can reflect back to them. Alcohol helps you relax, and it's important to you not to be considered an addict by others. So you captured both sides of that ambivalence. Summaries. They're types of reflective listening that summarizes discussed material. It demonstrates careful listening to what the patient's been telling you, and it also can prepare the patient to move on. So, and within a summary, you can also capture both sides of that ambivalence. And it allows the patient to hear their own change talk 3 times. So once when they said it, the second time when you reflected it back to them, because you always reflect change talk, and 3 times when you incorporate it into one of your summaries. So a summary could be something like this. So this heart attack has left you feeling really vulnerable. It's not dying that scares you, but what worries you is being only half alive, living disabled, or being a burden. In terms of things you want to live for, you mentioned your grandchildren and wanting to complete the work you've been doing, although not with the same intensity. What else? So that wraps it up for the fundamental skills. There's a lot more skills in MI that if you got engaged in a training program, you would learn. But we don't have time to go to them. So what I'd like to do is turn your attention, if you open up your handout, it's the next page after, how are we doing for time? Okay. There's a handout saying scoring a motivational interviewing session, and what I love about MI is that it's so easy to observe a session and be able to track the interventions that a person is doing. And as you track those interventions, then you learn more, and then you can easily give the person feedback. And so what I'm asking you to do is to track some interventions. I'm gonna show you a clip of tape of this guy who he does MI reasonably well. His name is Bill Miller, one of the founders of Motivational Interviewing. So we're going to have a chance to score him. And what I want you to do is every time you see an open-ended question, make a little hash mark. And then when you get to 4 hash marks, you can put a line through it, and that would be 5. Anyways, that's how I normally score. It's kind of like from, I don't know. And then you do the same thing with closed-ended questions, which you actually don't want that many of, and the rest of the affirmations, reflections, and summaries. All right, so if you have your sheet, we can turn on the tape. So I want you to look down and look at how many open-ended questions you had. Did you have any closed-ended questions or affirmations? Did you how many reflections? How many summaries? And what you might notice is, if we actually got you all to say how many you have, is that we might not all be in agreement about exactly how many reflections we saw, but what we look for is the ratio. And I wanted to say, did you notice something about the ratio of reflections to questions, either open-ended or closed questions? Did people notice that? Did you notice that there was a lot more reflections? Yeah. So that's what we want to go for in motivational interviewing. That's the 3-to-1 ratio, and actually I think it might even be beyond 3-to-1 with Miller. So then if Miller was a student, we could give him this feedback, and maybe if you guys want to, I could send it in an email to him after. You can tell me. So thank you. Whoops, this is not working. Thank you for your attention. We didn't have a slide of resources, but if you do want to learn motivational interviewing, then I highly suggest you talk to your managers. All right, thank you.
So we do have time for questions. Anyone who has one, if you'd just like to get up to the mic.
I'm wondering about one of the darn cats. The more that you hear somebody use the word need, I need to do this, I wonder if that would be important to note, because it might be a sign that somebody has got a lot of internal struggle, just like if I tell you you need to do something, if I'm telling it to myself, or if our clients are telling that to themselves, would that maybe even need some attention?
Yeah. Oh, absolutely. I mean, need is one of the strongest language of change. And to your point, a lot of times there's a conflict. I know I need to do something, but I don't think I can. And a lot of times that's the ambivalence. It's not a question of, yeah, I recognize the importance of change, or I need to change, but I don't think I can. And this is just from my own personal experience. A lot of the clients that come to us are not dumb. They know their lives could be improved. They don't necessarily like the way things are, but what holds them back is the ability piece. So we get a lot of, I need to do something about this, and I wish I could do something about it, but I can't. And it was talked about, we do a disservice if we spend all our time reiterating the need. Like, I can reflect that back, but it just adds anxiety, because if they don't think they have the ability to do something, that just keeps them stuck. So yeah, need is a very strong part of change talk, and I certainly want to capitalize on that. So I'd reflect that. Yeah, you recognize that there's some need here for you. How would your life be different if you did do something? What's kind of holding you back from implementing these things you want to do? So then we kind of shift the focus into the ability piece. So yeah, it's all important.
In your decisional balances, do you ever assign, Celine, sorry, do you ever assign weightings, or I guess I've had some experience with that when I don't really like it, but you know, sometimes people are quite equivocal, so.
Yeah, I mean, Zenobia and I have talked about this before, the different ways you can use the decisional balance, right? Like, and so I'm very clear in my 1, 2, 3, 4s and always going in that order, and I usually go do a box and stop, finish that box entirely, discuss it at length, move on to the next box. It usually takes about 45, 50 minutes, to be honest. Other people do them where they don't have a particular order, but then they get them to highlight the ones in each box that are the most important and discuss that part of it. So there are different ways that you can do it. I'm biased in my way, but because I think they're very, very rich, right? You can get so much information from them, so much of an understanding of the patients, and that's what you can build a lot of your more complex reflections from, is that decisional balance later. So sometimes, you know, I might do it in the depth I do and then bring it out at a later time and get them to highlight things or things like that, whereas Zenobia does it a little bit different.
So when the weighting happens, it happens from the perspective of the patient. They highlight what is important. However, if this is someone that I know well, or maybe I don't know them well, but I have an intuition that they're avoiding something, I can address that in motivational interviewing. Like, let's say there's something that they highlighted or something that they identified in their decisional balance, but they didn't highlight it as being important, but something inside me was wanting to look at that. I could actually do that, and I do it through an elicit. I ask them permission. I say, hey, listen, would it be okay if I told you something that I'm observing, or that I have a concern about? And if they say yes, then I say, okay, look, this reason that you wrote over here, but you didn't highlight it, I'm wondering if there's some reason why you didn't highlight it, or is there something going on with that? And then, so that's how I can, they weight it, and then I could add into that later if I felt a need to. Would you ever have a number? Like the importance in... You could. I haven't done that. One thing that I have done is I've added in values. Like if I've done a previous values, I get them to write their values on the decisional balance, and then I have them compare their highlighted ones to their values.
Yes, Dr. Abbas?
Thanks for your presentations. I was wondering, like, when you're doing this work, obviously it's going to stir up, you know, emotions and anxiety and everything else. I'm just wondering if there's a set sort of approach to that built into MI, to managing emotions and anxiety that get activated around the change process that you're helping them move themselves to, like in office kind of thing. Or how do you do it naturalistically?
You know, this isn't a scripted type manualized therapy, right? Like, it's not like you pull out and say, okay, we're going to do 8 sessions of MI. It really is a way of being with the person. So if you did see emotional content reflected in a statement, you would reflect the emotion. You would say, this is making you really upset right now. This is, you know, and then you'd move with that emotion. Emotion reflections are very, very powerful, and you would definitely use that to then talk about why, or use an open-ended question. You're very upset right now. What is bringing that up for you? But so I guess that would be something.
Yeah, so I see it as the reflection creates a container for it, and then the open-ended question allows you to explore it further. And emotion is very important. Is this that they don't, well, it's been a while since I read the MI text, so I don't know how much they talk about it, but you definitely reflect it.
Oh yeah, no, definitely. When you see emotion, you reflect it. 100%, because that can be so powerful for change, right? And something's bringing up an emotion that's really often reflects ambivalence. So you'd want to go after that. And if there's ambivalence, that means they're contemplative. That means you match your style of intervention to that contemplative state, which means you'd continue to do motivational interviewing. You wouldn't jump in with a more action-oriented stage of change.
Hi, I'm just curious about your thoughts on the idea of fairly immediately establishing treatment goals and how that fits or doesn't fit with a motivational interviewing approach.
Do you want to take this one, Scott? So I would only immediately establish treatment goals with someone if they were in the stage of change, like the preparation stage of change or action stage of change. If I was trying to establish treatment goals and they were pre-contemplative or contemplative, then I would be a mismatch, and that would probably create kickback in them, and they would stay stuck or resist against my change. So treatment goals come up, but they're it's when the client has moved in their stage of change to the action or preparation stage.
All right, well, thank all of you for a really excellent presentation.